Hey, hi everyone. Myself, Dr. Amit. I am junior resident in the Department of Radiodiagnosis at Aiims Hyderabad, and today we will going to discuss about genito-urinary system in radiology. So first, we will discuss about pyelogram. So here, pyelogram is also known as dye studies, and there are four sets of modalities in pyelogram, including intravenous urography, retrograde pyelography, retrograde urethrogram, and micturating cystourethography. So these are the four sets of modality in pyelogram. So first one is intravenous pyelogram. So intravenous pyelogram, it is a modality in which the pelvic calyceal system of kidney is observed. So the kidney is observed on both the sides and contrast is given intravenously. The intravenous contrast is excreted via kidneys provided both are present and functionally normal. So if the contrast is excreted, then we can consider that the both kidneys are functionally normal. Then ureter and bladder are observed. The urethra is not observed in intravenous pyelogram. When the bladder is full, the post-void residue is investigated in the patient. Now the next modality is retrograde pyelography. So retrograde pyelography, in which the pelvic calyceal system of the kidney is observed and in which the contrast moves in the retrograde direction, that is from down to upwards. So contrast going from down to upward, if it is undetectable, then we can consider is as the kidney is non-functional or entirely absent, as in renal agenesis. Now the next modality is micturating cystourethography. So it is the investigation of choice for vesicourethral reflux and posterior urethral wall pathologies. So in which we observed the urinary bladder and urethra. So bladder is filled with the contrast dye, and once the bladder is distended, the patient is urged to micturate. Patient micturates on the table only and a radiograph is taken as they do. So I said it is investigation of choice for vesicourethral reflex and posterior urethral wall. Obstruction is observed with dilatation of the posterior urethra. Now the next modality is retrograde urethrogram. In retrograde urethrogram, urethra is observed and bladder is not distended with contrast. Cannulation at the external urethral meatus can be seen and contrast flown from down to upwards. Okay, from down to upwards we can see here the contrast is given, and this is the preferred modality for anterior urethral wall evaluation. Investigation of urethral pathologies, that is urethral strictures, urethral injury or rupture, can be investigated by this modality. So if there is urethral rupture, then yes, there will be contrast extravasation. Okay, so this is about the all modalities used in the pyelogram, and this is also known as the dye studies. Now let's talk about the congenital anomalies of the kidney. So first one is horseshoe kidney, then we will discuss about pancake kidney. After that we will discuss about cross fused ectopia, then we will discuss about duplication or duplex moiety, and this all are the important congenital anomalies of the kidney and we should know about it. So the first one is horseshoe kidney. So look over here, this kidney appears like horseshoe shaped. Okay, now the two kidneys appears closed and joined along the midline. Can you see here? In the horseshoe kidney, the inferior mesenteric artery prevent the ascending up to the kidneys. So inferior mesenteric artery prevent the ascending up of the kidneys. Okay, so this might be the question in your examination. So has association with different kinds of syndromes or disorders, and most commonly it is associated with Turner syndrome. So here you can see that the U-shaped kidney. Okay, look over here, this is the CT scan while this one is the MRI. So look over here, in both these studies the shape of the kidney is U. Now This is known as joining hands or handshake or flower case appearance. Okay, so this is the horseshoe shaped kidney. Now the second one is pancake kidney, and in pancake kidney both the kidneys are located in the lower pelvis and join at the both pole. So in our previous anomaly, that is in horseshoe kidney, we see that only the lower poles are fused. So look over here, in this horseshoe kidney the lower poles are fused, but here you can see that both kidneys are located in the lower pelvis and joined at the both poles. Okay, in the horseshoe kidney the kidneys are joined in the one pole only. Okay, it can be lower or it can be upper pole. Now the next anomaly is crossed fused ectopia. So there are different types of cross fused ectopia. So here what happened is one kidney is observed on the other side with its ureter terminating on the right side of the bladder. Now the another pelvic calyceal system is observed on the right side with its ureter terminating on the left side of the bladder. So this is the crossed fused ectopia. Now there are different types. So this one is the inferior ectopia. This one is the S-shaped ectopia. This is the lump kidney. Okay, don't confuse this anomaly, that is lump kidney, with pancake kidney. Pancake kidney is occur in the lower pelvis, while in this anomaly the both kidneys are occurs on the same side. So this is the lump kidney. Then here the next type is L-shaped ectopia. Then this one is the disc kidney, and this one is the superior ectopia. So these are the different types of crossed fused ectopia. Okay, now look over here, what is the type of ectopia given in this radiograph? This is the inferior ectopia, in which we can see that on the right side with its ureter terminating on the right side of the bladder, and the another pelvic calyceal system is observed on the right side with its ureter terminating on the left side of the bladder. So this is the inferior ectopia. Now the next anomaly is duplication or duplex moiety. So two renal moieties can be seen, that is upper and lower moieties. So this is the upper moiety while this one is the lower moiety. When there is a complete duplication and the upper pole moiety is observed and non-functioning, then drooping lily appearance can be seen. So look over here, in which the drooping lily appearance can be seen. Ureter from the different moieties insert into the bladder. So upper pole moiety becomes non-functional due to obstruction. Therefore, upper pole moiety does not take up the contrast in the intravenous pyelogram as it's a non-functional. That's why there is appearance of drooping lily. Okay. Now upper moiety is not visualized in the IVP. That's it. Now let's discuss about Weger's-Mayer law. So Weger's-Mayer law describes the relationship of the upper and lower renal moieties in duplicated collecting systems to their drainage inferiorly. So in this law, with duplex kidney and complete ureteral duplication, the upper and lower renal moieties are drained by separate ureters, okay, each having its own ureteral orifice in the bladder. Now the upper renal moiety ureter has ectopic insertion medial and inferior to the lower renal moiety ureter and frequently ends in ureterocele, while in lower renal moiety ureter has orthotopic insertion, that is a normal insertion, and it is lateral and superior to the upper renal moiety ureter, and it ends with vesico-urethral reflux. So what is ureterocele and what is vesico-urethral reflux? So ureterocele is abnormal congenital dilatation of the distal most portion of ureter, right? And the dilated portion of the ureter may herniate into the bladder secondary to the abnormal strictures of VUJ, while vesico-urethral reflux is the term for the abnormal flow of urine from bladder into the upper urinary tract, and it's typically encountered in the young children. So Ureterocele is common in upper pole moiety while lower pole moiety is predisposed to VUR, that is vesico-ureteric reflex. Now let's discuss about urolithiasis. Urolithiasis means yes, stone in the kidney. But yes, stones are also found in the ureter, right? So most common pathology of the kidney is urolithiasis. Majority of the stones are radiopaque and most common renal stones are calcium oxalate. So for radiopaque stones, investigation of choice is yes, non-contrast CT. While for radiolucent stone such as uric acid and indinavir stones, the investigation of choice is dual energy CT, that is DECT. Now, what are the causes of nephrocalcinosis? So we divide these causes into two parts, that is cortical and medullary. So cortical causes are there might be acute cortical necrosis, Alport syndrome, graft rejection, hemolytic uremic syndrome, chronic glomerulonephritis, while the medullary causes are there can be because of distal renal tubular acidosis, because of hyperparathyroidism, sarcoidosis or hypercalcemia, medullary sponge kidney and hyperoxaluria that can causes the medullary urolithiasis. So these are the causes for nephrocalcinosis. Now look over here. This is the CCT of abdomen and this is the contrast. So what is this structure? Yes, this is the ureter. So this is the dilated right ureter and here we have the distal obstructing stone. Okay. Now look over here. This is also few stones, right? Now look over here. Here we have one stone, while look over this X-ray abdomen. Here we can see that there is one radio opaque body seen just right to the, this is the fifth lumbar vertebra, this is the fourth and this is the third. So just lying right to the third lumbar vertebra, there is one radio opaque body, right? So this is the radio opaque body and this is might be because of renal stone. Now look over here. Here we have the ultrasonographic image of the kidney. Can you see there are few echogenic foci? Yes, these are the echogenic foci. So ultrasound frequently the first investigation of the urinary tract, and although by no means as sensitive as CT, it is often able to identify calculi. So small stones and those close to the corticomedullary junctions can be difficult to reliably identify, but yes, ultrasound compared to CT KUB referred showed sensitivity of only 24% in identifying the renal calculi. Nearly 75% of calculi not visualized were which are less than 3 mm. So the features including there is echogenic foci that we as we discussed, and then there is acoustic shadowing. Can you see? This is the acoustic shadowing, and on color Doppler there is a twinkling artifact. Also you can see color comet tail artifact in renal calculi. So these are the characteristic features of renal calculi in ultrasonography. Now let's discuss about types of calcifications seen in the kidney. So there are few types of calcifications seen in the kidney like staghorn calculus, putty kidney, medullary nephrocalcinosis. So let's discuss about it one by one. So the first one is staghorn calculus. So the staghorn calculus takes up the shape of pelvis and calyces. So look over here, this is how it looks like. Staghorn calculus and ureteric calculus are observed in the X-ray. Staghorn calculus is a triple phosphate stone and it is most commonly associated with proteus infection, also known as Strowoid stone, and it has a coffin lid appearance. Look over here, this looks like coffin lid, okay, in microscopic examination. So this is the staghorn calculus. Now let's talk about the putty kidney. So what is putty kidney? Putty kidney refers to a pattern of a renal calcification associated with renal tuberculosis. The calcification can be large, rounded, oval, or dense, or very homogeneous or ground glass like, representing calcified caseous tissue with dilated calyces. This condition is due to superimposition of urethral obstruction on renal parenchymal tuberculosis. So look over here. Here we can see that calcification with lobulated appearance, that is, here there is a parenchymal calcification, appears white like cement. Okay, so this is the putty kidney observed in the later stages of tuberculosis infection, leading to non-functional kidney and orthonephrectomy. So this is the putty kidney. Now let's talk about medullary nephrocalcinosis. So medullary nephrocalcinosis is a commonest form of nephrocalcinosis and refers to the deposition of calcium salt in the medulla of a kidney. Due to the concentrating effect of the loops of Henle and the biochemical milieu of the medulla compared to the cortex, it is 20 times more common than cortical nephrocalcinosis. Now look over here. Can you see there are multiple echogenic foci and there is some space between it, that is, there is a medullary nephrocalcinosis, while look over here in this X-ray abdo, there you can see that there are lucent areas observed between the opaque areas. So these are the radio opaque areas and here we have the lucency between them. So it looks like the medullary nephrocalcinosis. Now let's talk about renal cyst. Renal cyst, it is a generic term commonly used in a description of any predominantly cystic renal lesion. The majority of parenchymal cystic lesions represent benign epithelial cyst. However, malignancy such as renal cell carcinoma may also present as cystic lesion. So renal cysts are sacs of fluid that form in the kidney, and most of the time they are simple cysts, meaning they have the thin wall and only water-like fluid inside it, and cystic lesions with thickened or irregular walls are suspicious of renal cell carcinoma and warrant further workup for vascularity of septa on color or spectral color Doppler. Now, there is a Bosniak classification used to group cyst based on malignancy. So, Bosniak classification categorization is done on contrast enhanced CT but not on ultrasound. Okay, so classes include Bosniak 1, Bosniak 2, 3 and 4. As the grade increases, the chances of malignancy increases and surgery may be required. So look over here. Here we have the Bosniak classification where we can see that Bosniak 1 means there is no septa. So in Bosniak 2 classification, few, that is 1 to 3 septas are there and the width is less than 2 mm. While in Bosniak 2F, 1 or more than 3 mm septas or many more than 4 septas and the size is less than 2 mm. But yeah, in Bosniak 3 classification, 1 or more cyst with width more than 4 mm and thick or irregular septas. And in Bosniak 4, 1 or more enhancing nodules are there. So this is the Bosniak classification. So Bosniak 1 and 2 are ignored, but Bosniak 2F has some unusual features and requires a follow-up. Bosniak 3 and 4 are planned to excised. So this is the classification. Now look over here. Can you see this is the ultrasonographic image of a kidney. Now this is the simple cyst and here you can see that. Now let's talk about the ultrasonographic feature of a renal cortical cyst. So look over here. Here we have a well-defined anechoic cyst with thin wall. Sometimes there might be few septas are present in a simple cyst, but here we cannot see any septa. Also, posterior acoustic enhancement may be present, although this finding is non-specific and also may not be seen with smaller cyst. Okay, so these are the simple renal cortical cyst. Now look over here. This is the complicated cyst. So why? Yes, the cystic lesion with thick or irregular walls and there are few septas are there and these septa are suspicious for renal cell carcinoma and warrant further workup. Vascularity of the septa on color or spectral Doppler is suspicious for renal cell carcinoma. So, these are the findings in ultrasonography for renal cyst.